Hello, everyone. We will get started in just 1 minute. We'll give a chance for more people to log on, and we'll start at 1 o'clock exactly. Okay. Hello, everyone. My name is Megan Glenn. I'm the National Manager of Programs at the American Liver Foundation, and I would like to welcome everyone to today's webinar made possible in support from Gilead Sciences, Intercept Pharmaceuticals, Abbvie Pharmaceuticals, and Genfit. I would like to thank Dr. Robert Gish, who will be sharing his expertise on today's webinar. Dr. Gish is currently a clinical professor consultant at Stanford University in Palo Alto and also an adjunct professor of medicine at the University of Nevada School of Medicine in Las Vegas. In addition, he is also medical director of the Hepatitis B Foundation in Doylestown, Pennsylvania, and a medical advisory committee member of the American Liver Foundation's Pacific Coast Division. Let's just get started with a few housekeeping things. On the upper right-hand part of your screen, you should see a dialog box. If you don't see it, there's an orange arrow you can use to expand the window. From here, you can ask questions. You can ask questions at any time, and we'll be answering them in the last 10 to 15 minutes of the webinar. We will get to as many questions as possible, and we welcome your participation, so please do send questions in. At this point, I will turn the slides over to Dr. Gish.
Greetings, everybody. This is Robert Gish, and we're going to talk today about liver disease and liver disease management. And I am just trying to get control of the screen. Megan, can you give me control back? Get there in a second. Hoping to get control here. Megan, it was working before. There we go.
Oh.
Wow. That is a lot of forward slides. Okay, I'm sorry, everybody. Your anti-vertigo medicine should be working now. All right. Megan, I don't know why it's doing this. May just have you take control, Megan, because it seems like I hit my page down. It goes forward 10 or 15 slides. Let's go back to home. All right, go forward. One more slide forward. Does not want to stay on those slides. All right, is that the first slide?
Yeah.
Okay, who should be tested for liver disease? Well, people who present with symptoms that may be liver-based or general symptoms such as fatigue or fever. A liver panel is typically part of that workup, even though liver disease may not be immediately suspected. People with high-risk behavior, especially for acquiring infections like hepatitis B and C or international travel where hepatitis A and E might be considered, would be very important to be testing for liver disease in those individuals, especially if they're symptomatic. More commonly, patients come in and just get a chemistry panel as part of a general workup or workup for non-specific symptoms, and elevated liver tests are seen. And then those patients need the multi-phase workup that we'll be talking about today. And there's the patient population who come in maybe with abdominal symptoms. They might even not have a chemistry panel or a chemistry panel liver test may be normal or near normal, but there's something abnormal on liver imaging. Megan, you go forward one slide. I don't know why it's jumping around. It was working so well before. Okay, mandatory liver disease testing. All right, we're on the next slide. some ghost has taken over our slides. Our apologies. We actually did a test and it was working just fine before. Megan, is there a way to slow down this slip back and forth? We're okay for now?
Something's wrong with the PowerPoint, but this should be your next slide.
Okay, so we'll focus on this slide for just a moment. In the old days, we would put every liver test into a basket called liver function tests, but current terminology, we split out liver enzymes and liver function tests. So AST, ALT, alkaline phosphatase, and GGT are liver enzymes. Those are not liver function tests. Bilirubin, albumin are typically part of a liver panel, and if you suspect coagulopathy, you would be getting an INR. That would not be in a standard liver panel, but would be part of a liver workup. There are other good liver function tests, such as lactate, glucose, cholesterol, clotting factors, and we'll talk briefly about what's called thromboelastography. I wanted to emphasize that ammonia testing is a very poor liver function test. I haven't ordered an ammonia test in over 5 years because I really depend on my physical exam and history when I'm considering the workup for hepatic encephalopathy. Next slide, please. There is a ghost in there. Okay, so elevated liver tests are noted on a panel. Really good ideas to repeat that panel a day, a week, or month, depending on the level of the enzyme elevation that's present. And mild elevations can be monitored for a month or two. Short-term interventions might be taking place, such as stop drinking, stop any herbal or supplements that are being taken. There may be some specific medicine that's suspected to be liver toxic that should be discontinued. And of course, if you've got patients who have done something high risk recently or high risk history, liver tests are elevated, I would recommend that you would move quickly to viral hepatitis testing, such as viral hepatitis B and C. Next slide. So what is an ALT that's elevated? And there's been some very interesting advances over the last 10 to 15 years where we've reset what a healthy ALT is. And currently the AASLD is either using 20 or 25 for women, 30 or 35 for men. We're no longer using 40, 45, and some labs even had 60 or 65 as a normal level, but normal is different than healthy. So I really like to use the word healthy for ALT, and it's the same range for AST. So either 20 or 25 for women, 30 or 35 for men for AST and ALT. And of course, you're going to take a symptom history, itching, liver pain, diarrhea. You're going to do a physical exam, of course, look for jaundice, look for signs of chronic liver disease, look for pulmonary edema, look for spiders. And of course, on the liver panel, you're going to look at the pattern, the ALT greater than the alkaline phosphatase, typically 2x or higher, would be a hepatitic type pattern. And if the alkaline phosphatase and GGT are higher than the ALT, that would be considered cholestatic. GGT we'll talk about is much more specific for the liver, and it's got other uses as well. Next slide, please. So in a patient with a confirmed elevated ALT, and this is an ALT that would be in the 60, 80, 100 range, these 6 tests need to be done on every patient. It's very inexpensive. It's about $60 and takes less than 6 minutes to get all these tests either done or ordered or reviewed, and that includes hepatitis B surface antigen, hepatitis C antibody, with of course a reflex to hepatitis C RNA if the antibody is positive, iron saturation, not ferritin, but you're going to be using iron saturation to work up that patient. You're going to take a good alcohol history and administer at least a CAGE test. You're going to take a medication, herbal, supplement, and look for dilly, hilly, silly, because there's a variety of different herb supplements, medications, over-the-counter medications, prescriptions medications that can cause liver injury. Then you'll do a full workup for metabolic syndrome. BMI is easy to calculate. Most patients will have a flat fasting or random blood sugar in their chart. Those patients will have a lipid profile. Waist circumference is very useful. And of course, you'll do a blood pressure for hypertension. Next slide, please. So etiologies, I'm not going to read through every part of this slide, but as you know, the slide deck will be downloadable. And there's actually a number of cases in this slide deck that we hid, meaning they're not going to be part of our discussion today. But we encourage you to download this deck for your own review and then for teaching purposes in your clinic or with your colleagues or in your community. So elevated liver tests, fatty liver, number 1, alcohol, number 2, hepatitis C, number 3. Then it depends on the patient population where hepatitis B might be more common. And of course, hereditary hemochromatosis or iron overload we talked about. I don't work up every patient with an alpha-1 level or an ANA or smooth muscle. I don't work up every patient for Wilson disease. Those are considerations in specific settings, especially if the phase 1 workup we talked about is normal. Next slide. Okay, I'm not going to go through this slide in any great detail, but I just wanted to say, as a liver specialist, if that first 6 workup tests are negative, I start thinking about everything that's on this slide. And of course, we mentioned Wilson disease. If there's a site history, low uric acid, high bilirubin, but a normal alkaline phosphatase, alpha-1 I'm going to consider if they have lung disease or there's a family history. There's a cholestatic pattern. Of course, we're going to be doing liver imaging and be looking for gallstones, malignancies. If they've got a history of foreign travel or foreign-born, be thinking of parasites. And there's some other autoimmune and infiltrative diseases. And this is the point where you'd start thinking about a biopsy in patients. But biopsy is really a 2nd or 3rd level procedure for patient investigation. Next slide. All right, so we've been talking about chronic hepatitis because that's the most common thing that we see. So for every 100 patients you see with chronic hepatitis, you might see at most 1 patient with acute hepatitis. And I usually have a cutoff of about an ALT of 200, trying to get a history that the patient has no liver history. This may be a high ALT with or without an elevated bilirubin, but I'm thinking for acute hepatitis, I'm thinking of a different profile. And of course, this should be a different panel. I just want to let you all know we're working with Quest, and hopefully we'll work with LabCorp this year with one of our advocacy groups to try to get these panels really cleaned up on their ordering site and how results come through. Hepatitis A we talked about, hepatitis E for people with foreign travel, or if they have some type of high risk exposure in the United States, such as eating raw or uncooked pork or liver or other meats. CMV, if they have a rash, it's a little bit more common in pregnant women. Epstein-Barr, rash, lymph nodes, mononucleosis type pattern on CBC. And of course, on the right side, you're going to think about doing a tox screen, think about drugs of abuse. We've talked about different types of herbals or supplements. Anybody with acute liver injury, I'm going to get a blood alcohol, I'm going to get an acetaminophen level. I'm going to have a low threshold to get a Doppler test. And of course, in women who are of childbearing age, a pregnancy test should also be a consideration. Next slide. So AST and ALT are liver hepatocyte dominant, but remember AST can also come from muscles. We talked about what those healthy levels are, and this could either be damage with leak or cell death that leads to elevated AST and ALT. Next slide. All right. Let's talk about alkaline phosphatase just for a moment. Go forward one more slide. This is liver semi-specific, but remember alkaline phosphatase also can come from bone. There's a lot of vitamin D deficiency, although there's also a lot of controversy about what constitutes vitamin D deficiency in supplements. Elevated parathyroid hormone can also cause an elevated alkaline phosphatase. So next slide. GGT is really my next favorite liver test after ALT because this is very liver specific. And an elevated GGT would typically mean that there's some type of inflammatory process that's around the bile ducts or obstructive process around the bile ducts. Next slide. Go forward one more. So this is very interesting because we have so much going on in NASH. We have such an overlap between metabolic syndrome and the liver, heart disease, metabolic disease, diabetic disease. This is GGT as a predictor of cardiovascular events and mortality. Once I got this review, it really changed how I thought about GGT. And it's very interesting that it can predict cardiovascular events even independent of BMI. Some of these publications are quite recent, up through 2013. So even though the GGT is coming from the liver, it's a marker of inflammation. Inflammation is a marker of cardiovascular risk, events, and mortality. So when you're working up a liver patient, GGT should be part of your liver panel and your liver workup, even though it's not in a standard liver panel. There's a long story about why that happened. It has to do with Medicare and some foolish decisions in the early 90s. Next slide. All right, so now of liver function test, bilirubin's the best. This is better than albumin or better than INR. And the bilirubin, to be a good liver function test, should be fractionated. So a direct bilirubin is your best friend and you're assessing patients for liver dysfunction. So if you've got a bilirubin that's over 0.7, you should be fractionating that bilirubin and assess the direct bilirubin. A direct bilirubin should be less than 0.3. Once you get to 0.3 or higher, that indicates some level of liver dysfunction, and that is your best test to follow. So bilirubin greater than 0.7, fractionate, and then look at the direct bilirubin. So if the bilirubin is 1.2, and the direct bilirubin is 0.2 or 0.1, that patient probably has Gilbert syndrome. Next slide, please. All right, bilirubin can occur from overproduction of bilirubin, such as hemolysis, impaired uptake, or conjugation or excretion, such as Gilbert syndrome, obstruction of bile ducts, and this results basically in a regurgitation, and also a decreased transport, so that can be high in the blood and also shows up in the urine. Next slide, please. Albumin, a good but not a great liver function test. Albumin's made by the liver, but it's sort of a inverse test to inflammation. So the higher the C-reactive protein or the higher the sed rate, the lower the albumin would be. And really a healthy person should have an albumin greater than 4. So if someone's got a high ALT or GGT and the albumin's 3.6, to me that's a marker of liver dysfunction. Or as I mentioned, I would be looking for inflammatory states. Heavy alcohol consumption can drop the albumin, HIV, protein malnutrition, other types of chronic inflammation, maybe an autoimmune disease. Next slide. So INR, also a good but not a great liver function test. And the INR and ProTime are really designed to assess patients who are on Coumadin or anticoagulation therapy. They were not designed to really test risk of bleeding, either spontaneous bleeding or bleeding with therapeutic interventions. So we're going to talk about TAG. Next slide. So TAG comes in two forms. There's a classic TAG machine, and there's also the Rotem technology, but they have the similar idea about putting whole blood in a cup and then a rotating pin or spindle or cylinder. And that rotational velocity decreases as blood clots and forms tension between the cup and the cylinder or internal cup that's inside the bloody or the blood reservoir. And here's what you see. Next slide. So you're going to see a diagram that's going to come out of a machine that might be on a piece of paper, but much more likely to be in a computer or on a screen. And you're going to see this different shape that looks sort of like a spindle. That left first line is the line that is an R value that has to do with coagulation products that are vitamin K dependent, similar to what you might see with an INR. Then this alpha or angle, or also it's called a K value, gives you fibrinogen function. Then the next you're going to look at is that width of that shape, the MA or maximum amplitude, is what takes place when you have platelet function or platelet dysfunction or platelet deficiency. If this doesn't stay wide and it starts coming back to the central line, that means you've got lysis, fibrinolysis, DIC taking place. So this machine, one test is about $60, and it tells you, do you need to give fresh frozen? Do you need to give fibrinogen? How much fresh frozen? How much fibrinogen? What's the platelet function? Do you need to give something to block a DIC condition? Very, very useful tests. Most useful in a hospital setting, but if you have any liver dysfunction and you're trying to manage that patient, this is the best test. Next slide. And this gives you some other patterns. I hate to say this, but they look like a lot of different types of alcohol glasses, such as a champagne flute or a Pinot Noir glass or a cognac glass of some type. But this really gives you different shapes with different diagnoses. And of course, there's numbers associated with this that helps you decide what's going on and how to manage the patient. Next slide. Okay, what about the pregnant patient, a woman who comes in who's pregnant? You need to get a full liver panel, but the most important part of the liver panel for that mother is surface antigen testing. Surface antigen's positive, then of course a full hepatitis B workup needs to take place with hepatitis B DNA, and we'll talk more about hepatitis B in a moment. You're going to vaccinate women who are of childbearing age who are triple panel negative. We no longer vaccinate patients who are core antibody positive. Those patients have been exposed, probably have residual disease in their liver. Vaccine's not of any major benefit. Next slide. So how high is the ALT? How high is the alk phos? What's the pattern? What's normal? What's healthy? History, workup, pregnancy, exercise. You're going to put all these pieces together to decide what to do next. Next slide. So you're going to go back to the chart. Liver test elevated 2, 3, 5 years ago. We talked about a variety of different symptoms such as pruritus or fatigue, liver pain, weight loss. And then, of course, if you're suspecting end-stage liver disease, you're going to do an eye and skin exam for icterus and jaundice, look for ascites on physical or by ultrasound, take a history or potentially measure to see if they're having GI bleeding. What other medical problems? Diabetes would be a hint they might have NASH. Is there a family history of liver disease? You might think of Wilson or alpha-1, hemochromatosis. Does a person or a family have a history of autoimmune disease? Were they traveling to Italy and ate raw sausage? Just take a somewhat detailed history. Next slide. The medications, when a lot of patients hear the word medication, they only think that you're asking about prescription medications. So really talk about over-the-counter, herbal, supplements, prescription. Then you might even say bodybuilding agents or weight loss treatments. Those all would be potentially in the mix. Vitamins, where occasionally you can have vitamin overdoses, such as vitamin A. Next slide, please. Social history. How much do you drink? Is there a drinking problem? Any recent travel, born abroad, blood transfusions, kidney problems, kidney failure, needle sticks, tattoos, dental procedures, especially outside the United States, drug history, sexual behavior, any war experience or blood experience. Next slide, please. Physical exam, we talked about looking for signs of chronic liver disease, end-stage liver disease, very important part of working that up. As a provider, hands on the patient, Look at their ankles, look at their hands, look at their teeth, look at their face, look at their upper chest, all part of that liver workup. Next slide, please. So abnormal ALT, elevated alkaline phosphatase, and GGT. Most common diagnosis is fatty liver. Ultrasound's very good for picking up fat in the liver, and ultrasonographers, radiologists will often read that and put that in their report. Now, if you have a liver that looks slightly abnormal, but the person really doesn't look to be at risk for a fatty liver, or the alkaline phosphatase is in the 200 range, or GGT, at least twice the upper limits of normal, say in the 120 range, I'm going to have a low threshold to check an anti-mitochondrial antibody. We don't want to miss primary biliary cholangitis. We have multiple medications that can intervene, and either directly we have data that they prolong life or delay or prevent transplant, or inferentially that treatment can decrease alkaline phosphatase, and that is a correlate of risk of progression. Alcohol, yes, that can cause a cholestatic type pattern. Acute alcohol injury, which is not that common, but that can cause the AST to be higher than the ALT. Although most patients who've got that inverted AST to ALT ratio probably have advanced fibrosis or cirrhosis, because as cirrhosis progresses, there's an inversion in that AST and ALT pattern having to do with how much cytoplasm and mitochondria there are. We've talked about biliary obstruction and abdominal imaging. Next slide. So these are some scores. There's you can go online and get the NAFLD index, NAS or NIS scores. There's different things that are easy to calculate that are taken from the chart and from laboratory tests. So both these NAFLD index or NAFLD fibrosis score have online calculators that have information and calculations that can easily be done. That helps you assess the severity of their liver disease. Next slide. Also, to assess liver disease, this has to do with how much fat or how much scar tissue, how advanced is the fibrosis, elastography, and there is a specific type of elastography machine. It's under the brand name of FibroScan that also includes a CAP score, CAP, it's controlled attenuation parameter. It tells you how much fat is in the liver. There's other forms of elastography or blood tests such as Abbvie or FIB4 are going to predict the level of fibrosis. Blood tests, FibroSure, FibroTest, FibroSpec, which are in the $300 to $400 range, which I rarely use, also help predict how much fibrosis, although you can have false positives because of very high liver enzymes. And we talked about the NAFLD and NAS score. The multi-scan that's listed here, we're going to talk about in a few moments. Next slide. Alcohol. You can take an alcohol history, a CAGE, or a mass test. Of course, you can do a blood alcohol or urine alcohol. There's a new hair test that's sort of a hemoglobin A1C to look back 6 or 8 weeks for alcohol exposure. And a high MCV in a liver patient usually would support that person has an alcohol problem, although you have to double check B12 and folate levels. Next slide. This is more information on this hair alcohol testing. It's looking for what's called an ethyl glucuronide and also looks for fatty acid ethyl esters. This usually has to be done through some type of test center. I haven't been able to get LabCorp or Quest to access this. Needed about 200 strands of hair, but it's a very accurate, call it most sensitive and specific testing. Next slide. Full abdominal ultrasound is very important. In the old days, they often would just look at the liver and not really give you much other information. So when you're working up a patient for liver disease, Megan, if you could go forward one slide, you're going to ask for a full abdominal ultrasound. You're going to ask for a spleen size and portal vein diameter. That also helps assess for the level of portal hypertension that a patient may have. It's called the 12-12 rule, 12 millimeters for the portal vein or 12 centimeters for the spleen. If it's greater than that, you probably have portal hypertension, probably need an upper endoscopy. Liver texture can be assessed. Look how much fat's in the liver. Liver surface can be smooth or nodular. How big is the left lobe? How big is the caudate lobe? Of course, a Doppler study will give you information on blood flow. Next slide. There's a tool called a multi-scan. This is a very interesting test that's becoming more easily available. It can give you information on fibrosis, how much fat, and how much iron is in the liver. It's quite interesting. There's a score also that's derived from this information. It's LIFT score. It quantifies liver inflammation. So it's becoming more used, more available. And I suspect that more and more scanners will have this. Next slide. All right, this is just having to do with outcomes. And if you've got a high score on this multi-scan, there is some level of prediction of potentially developing complications in the near term, such as encephalopathy or liver cancer, ascites, but it's all about measuring how advanced their liver disease is. Good, not great, but it's interesting information that will be coming out of scans using these calculations. Next slide. All right, a little bit more on that NASH workup. We talked about the ALT and AST cutoff that's healthy. You're going to look at glucose, hemoglobin A1C, hypertension, BMI. We talked about waist circumference and abnormal ultrasound may be an intake. I always look at the platelet count. It's not a liver function test, but it's a test that relates to how big is the spleen, how much portal hypertension there is. I'm going to go online, look for this NAFLD score. And if I'm seeing a number of different significant clinical signs here, this is when you want to get a liver consult and, of course, consider an upper endoscopy, consider starting HCC surveillance, and potentially be more aggressive with weight loss. Even people who have fatty liver and cirrhosis who lose weight do better. Next slide. All right, so these are my numbers. If you've got a platelet count around 170, 100,000, that's F3. Under 100,000, that's F4. And none of these tests stand alone, but you're going to be looking at these in combination. An AST higher than an ALT, very likely to be cirrhosis. AST to ALT ratio is between 0.8 and 1, very likely to be F3. Next slide. Take some time, take some history, consider at least an ultrasound. We've talked about inexpensive blood testing for the first phase to get that patient worked up properly. Next slide. So what about treatment? Well, we talked about working up things, and we really want to talk about linkage to care. NASH, you suspect fatty liver, with fibrosis. Weight loss, exercise, lifestyle, diet is the best. I do have a website where there's a weight loss contract that I use for all my patients. These weight loss contracts, I think, are very effective. Hepatitis C is curable, as you know. We can get to 98, 99, 100% cure with hepatitis C, and now the standard of care. If someone's RNA positive, they should be treated unless they have a expected very short lifespan. That's really the only absolute contraindication to treatment today. Hepatitis B, you've got a patient with active liver disease, significant fibrosis. You can suppress them with our 3 first-line drugs, entecavir, PDF, or TAF. TAF is the most recent addition to our armamentarium with significantly less renal and bone effects than what we saw with TDF, even though with TDF, the risk of renal and bone is unusual, but we're putting everybody on long-term treatment. So you really want your medicine with your best safety profile. We talked about alcohol and interventions with an alcohol contract, AA, blood alcohol testing, inpatient or outpatient rehabilitation. Hemochromatosis, of course, phlebotomy and considering screening and then surveillance for liver cancer. Autoimmune hepatitis, we've got great treatments. I usually start with budesonide, mycophenolate, although some older treatments such as prednisone and Imuran are still considered. You've got dilly, hilly, and silly, but you're going to stop potential offending agents and then implement follow-up in those individuals. Next slide. Okay, what does all this mean? We know that liver cancer, 6th or 7th most common cancer in the world and 2nd most common cause of cancer death in the world. Hepatitis C, we have probably over 4 million people infected today, over 5 million who are antibody positive. We've got a cure. Hepatitis B, when we do interventions with our oral hepatitis B medications, we change outcomes. We decrease risk of progression to cirrhosis, cancer, death, and transplant. Primary biliary cholangitis, we've got a 1st and 2nd line medication that we think the data is compelling that it changes outcomes in those patients. So we really need to think about liver disease today because we have good therapies for most common causes of liver disease, and we have some great therapies. The advent of hepatitis C treatment and cure has been one of the greatest events in medical history, and definitely in the last 30 to 50 years, once penicillin got out. And we have a new drug, options, a number of options to cure hepatitis C. Next slide. So, liver function tests are different than liver enzymes. We got to really make that distinction because patients, when they hear liver function tests are off, they're worrying about having cancer or being on a transplant list. Their liver enzymes are elevated, but their liver function is normal. That type of communication provides a lot of reassurance to your patient. Of course, you're working these patients up. They've got chronic liver disease. They should not be drinking. And of course, you can eliminate unnecessary medications, herbals, and supplements. Next slide. So we talked about rechecking, and it depends on the level of elevation, how soon you would do a recheck. We did talk about the hepatitis B triple panel. So when you're working up hepatitis B, everybody should get a surface antigen, surface antibody, and core antibody. Surface antigen means infection. Surface antibody means immunity, vaccine-induced immunity, if core antibody is negative. Core antibody is very specific, meaning the false positive rate today with lab tests such as what we have with the Abbvie is one example. That core antibody test has a false positive rate of about 2 per 1,000. If you have a positive core antibody, that indicates that person's been exposed to hepatitis B and has some residual hepatitis B in their liver and should be linked to education about possible reactivation. Iron saturation, very important for iron workup. Ferritin is like a severity or C-reactive protein. It's a marker of inflammation. It's not good for working up patients for iron overload. Liver tests remain elevated. Your first phase of testing is not productive. Then you really need to walk down more significant workup, such as for autoimmune disease. One thing that I do today, if I have elevated iron saturation, instead of doing a liver biopsy, I send them to the MR scan. I can maybe use the multi-scan we talked about, or an MR scan that's set up to quantitate iron. It's so much more accurate than doing a liver biopsy, and obviously minimally invasive. Next slide. All right, elevated liver tests. We've talked about acute versus chronic. We talked about serology for infectious diseases. We talked about serology for autoimmune diseases. We talked about a multi-phase workup to be cost effective. We talked about patterns of liver enzymes to help take you one direction or the other. And remember, 2 other conditions. Thyroid disease can make liver tests high, and celiac disease, SPRU, cause elevated liver tests. And that, again, is just part of that celiac syndrome or gluten sensitivity. Next slide. So anything else on this slide? I think we've really talked about the big 6. And on this big 6, we are going to add a number 7, which is to have a low threshold to do an abdominal ultrasound, a full abdominal ultrasound with measurements of spleen and portal vein size. Next slide, please. So we talked about ultrasound. We talked about a full abdominal ultrasound. To measure spleen and portal vein size, you typically need a Doppler. Then the next time I'm going to do an ultrasound is typically in a cirrhotic patient when I'm doing surveillance for liver cancer. And I may do a Doppler once a year to look for portal vein thrombosis, which occurs typically in cirrhotic patients, up to a third of patients. And then, of course, you're going to do a referral to a gastrohepatologist and be thinking about doing a liver biopsy, sometimes being used to diagnose a disease, such as autoimmune disease, or to stage the severity of their liver disease if your other non-invasive testing is inaccurate or not correlating. Biopsies are being done much more rarely now than 5 to 10 years ago. Next slide. Management of mildly elevated liver enzymes. This is an algorithm that you may want to keep handy. I think it's quite useful and integrates what we had talked about through the rest of this presentation. Trying to see if there's anything else new on here, but this is just a nice flow sheet that you can use in your practice. Next slide. All right, so I think we're close to that 45-minute mark, and let's move to Q&A.
Okay, great. Thank you very much, Dr. Gish. So the first question is, HDV is a rare disease, but nowadays incidence of HDV is consistently increasing, even in developed countries like America. Maybe due to increase in diagnosis rate, could you tell us what the rate of treatment among HDV diagnosed patients is?
All right, let's just talk about prevalence of delta hepatitis. Everybody, I think, knows that delta is a piggyback virus that lives only in the setting of hepatitis B. And you're only going to find it, I'll make a general comment now, in patients that are surface antigen positive. So if you have a surface antigen positive patients, either you test everybody for delta antibody or you test selectively, but have a very low threshold to test because the mortality rate with delta is about 70%. We think in the US today that the prevalence rate is at least 5 to 6% across all patients who are surface antigen positive. There was a paper that came out from Johns Hopkins just a few weeks ago that looked at a little higher risk population, but hepatitis B infected individuals, and delta was about 15%. Once you have a delta antibody positive, you need to reflex to a delta RNA quant. That will be available through Quest in about 6 weeks. And there is a delta RNA quant that's available through ARUP in Salt Lake City. Use that as a reference lab. The only treatment that we have today for delta is interferon with a cure rate that really is probably only about 15%. This virus is difficult to cure because hepatitis B is not curable and it piggybacks on B. But there is a number of new drugs that are going into clinical trials for delta, who I'll mention at the highest level is lonafarnib, which is a global study that just got started about a month and a half ago. And the other one is Mercludex, which is an entry inhibitor that's in studies, I think, in Europe, maybe in Canada. That's the delta story in short.
Okay, does the hair test give us a sense of the amount of alcohol used in the past 8 months, or is it just a yes or no test? Use alcohol versus not?
My review, I haven't actually ordered the test yet, but my review of the data is it gives you a good idea of alcohol exposure over the last 6, 8 to 12 weeks. So if someone's drinking a glass a day, you're going to get a very low value. If someone's drinking a 6-pack a day, you're going to get a high value on this ethylglucuronide test. And there's a number and a report out, and some I'll tell you crude, but a more general correlate with alcohol exposure. So yes, you do get a semi-quantitative exposure level.
Okay, the next question. If ferritin is high in pediatric patients, but other initial liver tests are negative, what would be next? Any thoughts or comments?
So a high ferritin, but normal liver enzymes, I'm going to go and do tests for inflammation in that child, in the pediatric setting. Of course, I'm going to look at the iron saturation. The ferritin's high and the iron saturation's normal. Again, I'm going to go and look for, do they have chronic otitis? Is there a bladder infection? Do they have inflammatory bowel disease? I'll be looking for inflammation. There are some rare other conditions, genetic conditions, that with iron overload, where you get a high ferritin, but you may not have a high iron sat. But that type of workup needs to go to a pediatric hepatologist.
A follow-up to that is, what about in the autism setting?
Autism and a high ferritin, I would defer that to a neurospecialist, an autism specialist. I still think that ferritin's a marker of inflammation, and I think that would probably apply to that diagnosis.
Thank you. Someone is requesting that you discuss a little bit more about elevated ammonia levels in treatment.
All right, so as I mentioned, I don't order ammonia testing. We have a saying in the hepatology world that people that order ammonia testing are more confused than their patients. And that is because ammonia, even though it is CNS toxic, it requires interactions with other events to really be neurotoxic in this glutamine pathway, glutamine cycle. So if you've got an inflammatory process and a high ammonia level, you may have encephalopathy. But if you have no inflammation, a high ammonia level may not correlate or be indicative of hepatic encephalopathy. So I think ammonia testing is useful in drug development and research settings, but I don't find it useful in the clinical setting. I find it very confusing where people pour lactulose into patients to bring the ammonia down, and they forgot to try to fix the sodium, or they're not actively treating the spontaneous bacterial peritonitis or a pneumonia that's ongoing. So really the best way to work up hepatic encephalopathy is to look for asterixis, day-night sleep reversal, change in handwriting, change in memory. In your cirrhotic patients, you should always be taking a history about falls, and falls in a cirrhotic patient, in my opinion, is a good marker of hepatic encephalopathy.
Okay, and as far as alcohol tests go, the question is GTT like higher in more alcohol exposure?
Yeah, so the GGT is sensitive to alcohol exposure, but a high GGT should not trigger you to diagnose alcohol abuse or alcohol dependence. That is a diagnosis made by taking a full history.
And another follow-up from that, is GGT a valid way to look at alcohol exposure when someone is cirrhotic?
Less useful. Alcoholism, alcohol abuse, you really have to focus on taking a history from that patient and taking from a support person and making sure those things cross-correlate. GGT helps a little, AST to ALT pattern may help a little, high MCV might make you suspicious, but you just need to be a good historian when you're dealing with alcohol problems.
Okay, this user said, I'm trying to find weight loss info for patients with NASH on the provided website, robertgish.com, and could not find. Is there any specific tag on your website?
My web programmer was supposed to tag that weight loss contract. It should be under resources. And if it's not easy to find, I'm going to contact my web person. Of course, my email address is my name, rgish@robertgish.com. You can send me an email and I'll send you the weight loss contract.
Okay, great. Okay, that seems to be it for the questions. Thank you again for your time, Dr. Gish. I would like to also thank Gilead Sciences, Intercept Pharmaceuticals, Abbvie Pharmaceuticals, and Genfit for their support on this webinar. As Dr. Gish stated, we will be posting this recording on our website, as well as the slides, so you can view these at a later date. If you have any additional questions, we'll be able to answer them after. If you email education@liverfoundation.org, they will get to us, and I can share them with Dr. Gish. Any closing remarks, Dr. Gish?
No, I definitely want to thank you, Megan, for all your help with these slides. I borrowed these slides or used these slides from a number of people. Carrie Frenette's a close colleague who's always put together great slides and cases. I definitely encourage people to download the deck and look at the cases and work through those. And really, one of my most important messages is change from that old LFT terminology and separate that out. Liver enzymes versus liver function, acute versus chronic, magnitude, do a physical, do a good history. I think those are important. And I definitely want to thank all of our supporters. We're in a whole new era of managing liver disease. It's incredible.
Okay, thank you. With that, we'll bring the webinar to a close. Thank you all so much for participating today, and sorry again for the technical difficulties we had in the beginning.
Slides are live. Thanks, everybody. Thanks to the ALF, American Liver Foundation. Wonderful.
Thank you.
Bye.